Assalamu alaikum. Good afternoon, everybody. This is a clinical case presentation. I think it will create a good discussion. This patient came to us last Eid al-Fitr holiday in the early morning with the chest pain. This is his ECG in the ER. It showed that he has inferior MI, 36 years old. He's a smoker. He had in his history coronary angiography 2 years ago in another center where he was told to have a widening of his coronary arteries. So he was put on aspirin plus the warfarin anticoagulation. And 9 months before presentation to our center, he was told to stop his warfarin because of through the gastroenterologist because of GERD. Our decision was to take him to the cath lab for primary PCI as he had the chest pain. This is his RCA angio. You can see it is a diffuse ectatic vessel with some filling defects in the middle third and total occlusion in the distal third. This is his left coronary system. There is also ectasia of the vessels with stenosis in the middle third, including the second diagonal. Another view from other sides may be that the LID lesion is not that, as it was shown, that it may be not significant. So my decision was to try to recanalize the the RCA, sorry. We just passed the wire, and as you see that the occlusion has been released, and there is a significant stenosis at the crux, including the PDA takeoff and the distal RCA as well. So I was a little bit optimistic at this side that I did not see much of the thrombus formation in the vessel, and everything have been washed out. I proceeded with the dilatation. I took a 2-0 balloon, and we inflated at the crux. And this is the post-balloon dilatation. It was still optimistic. So I took a bigger balloon, 4-0. But the results was not that optimistic. The flow was disturbed again with no flow. And there is some haziness just before the crux. I gave nitro. It did not help much. I stayed there. What should I do? Should I send the patient to the CCU with the heparin and 2B3A blocker, or should I proceed with reinflate another balloon or stent in? Yeah.
Dr. Khoja, why don't we ask the panelists here? By the way, Dr. Samih Hawand, I did not introduce him here. Dr. Al-Majid, what will you do in this case? So this is an ectatic right coronary artery full of clot. What would be your advice in these cases?
Yeah, sir. I think this patient was subjected to coronary angiography 2 years before this presentation, so he was given an oral anticoagulation based on the diagnosis of coronary ectasia. And we have seen typical inferior myocardial infarction and a lot of thrombi, a big thrombus burden in the right coronary artery. So I will do only thrombectomy, and then I will give 2B3 receptor antagonists, which can be given for 24 hours or 48 hours, and then re-angio him to see the thrombus burden and if he's a candidate for stenting or not.
So then, basically pharmacological therapy and then bring him back.
Yeah.
Dr. Mohammadi, what would your approach be?
Can you hear me? Yeah, everyone can hear me. So yeah, I agree with you. I mean, this is a good strategy. One other thing that I might think about is just to give an intracoronary TPA if it's available in the cath lab, and get another shot and see where we are. If no much improvement, then I would just send the patient to the CCU and re-angio again.
Okay, Dr. Samir?
Actually, I will disagree a little bit here because this patient came with ongoing acute STEMI. And so I cannot delay this patient once I am in the cath lab. The question is, how should I estimate the burden of the thrombus? And it's very misleading in the presence of ectasia. We usually underestimate the size of the thrombus. If we don't see it, it doesn't mean it is there. It's not there. So I would have started without ballooning with actually a suction catheter and try to improve the flow. And now the decision about whether or not I'll do pharmacological treatment as opposed to full board stenting, that will come after I've removed some of the burden.
Okay, Dr. Ahmed?
So most likely I will try to open the artery because patient coming with a STEMI, at least to balloon it. If I see a lot of thrombus like this, I will stop and then I'll send patient into B3A for 48 hours. I'll bring it back.
So it seems that in our panel there are two people who are in favor of conservative approach, cooling down, and others feel that an attempt to open the artery in the cath lab because of the fact that it's a STEMI patient, I'm assuming he still has chest pain.
In the cath lab, after we open this, no.
At this point.
He's in the acute MI.
So he still has chest pain
Yes.
right now. Okay. So why don't we move on then? Can you carry on?
So I took what Dr. Samir thought of, that he's in an acute situation that we shouldn't delay that reopening of the vessel again. So I decided to proceed with stenting. This is the stent inflation in the cracks. And this is the view post-stenting. This is the stent area. There is a formation of thrombus inside the stent, plus the haziness which was there before as well. So what's next again? Stent implantation did not improve much. Actually, it made it worse also.
Okay. So carry on, Dr. Abdullateef.
At this stage, I decided to send the patient to the CCU and start him or continue the heparin IV plus 2B3A blockers, and for at least for 24 hours. After this, I brought him next morning down to the cath lab to see the results. The RCA is occluded, completely occluded, just before the stent. And no distal perfusion. So, should we return him back to the CCU and continue for another 24 hours or 48 hours of 2B3A blockers? Or should I proceed with reopening of trial of reopening of the occluded RCA? I decided to proceed and pass a wire and see how does it feel inside the stent. Then I inserted the aspiration catheter, not much actually. Yes, there are materials coming out, but it's not much. As I expected that it is a total occlusion. This is after multiple aspirations. The flow is a little bit better. PDA is lost here. Filling defects before and maybe at the stent area. So I used a balloon 30 by 20. I did multiple inflation down. Baggy too slow. 2 or 3 slides. Maybe. And this is post-multiple inflations, balloon inflations. The distal posterolateral branches are appearing, but the PDA doesn't appear. I tried to recanalize or to repass a wire in the PDA, but I failed. But I did not insist much over that. At that time, I thought that I will leave it for the time because my plan was to bring him in 3 to 4 months again for the LID and controlling the RCA as well, and maybe doing the LID. This is his file and angio. The LID, the PDA is not there, but the distal posterolateral is there. I discharged him on aspirin, Plavix, and warfarin again. I tried to contact him in 3 months' time because he missed his OPD appointment. Because he has an insurance, he went to a private hospital and followed up there. And the physician there or the cardiologist there changed his Plavix to ticagrelor.